Mic test, mic test. Could you please tell me if you could hear me? Thank you. Mic test, mic test. Can you hear me? Thank you so much. Okay, it's 9 o'clock, so let's go ahead and get started. Okay, thank you so much. Good day to everyone. We have a very good representation of countries and nationalities today, and it is exciting to welcome all of you. My name is Dr. Tom Madayag, who will serve as your lecturer in today's webinar. I am a consulting faculty for MedProU and a full-time professor at Broward College here in Florida. I am an adult gerontologic nurse practitioner, and I have been teaching ECG to paramedics, nurses, and physicians for over 30 years. So why are we here today? Well, we are here today because hopefully to accomplish two objectives listed on the slide. These objectives were set because an expectation of the acute coronary syndrome, or ACS protocol here in the United States, is that healthcare professionals must obtain and interpret a 12-lead ECG on a patient within 10 minutes of presentation. It is imperative, therefore, that as a practicing nurse in the United States, you must be proficient in identifying a patient or the type of MI called STEMI. Early identification of the presence of this type of MI will save cardiac muscle, and that is why it is important. Distinguishing patients with unstable angina from those with acute MI may be impossible during the initial presentation because their signs and ECG findings may be identical. Thus, it is necessary to have a combination of ECG findings, history, cardiac biomarkers, and other test results in order to confirm the diagnosis of myocardial infarction. So most, if not all of you, have seen a 12-lead ECG. Why is it called the 12-lead ECG? It is called such because it offers 12 different views of the heart. It is obvious that 12 different views offers more advantage than a single view. Hence, we use a 12-lead to diagnose the presence of a myocardial infarction. I must emphasize that you should not interpret the presence of a myocardial infarction just because of an abnormality in one view or one lead. The changes in one lead should be corroborated by other related leads. So let's take a look at this 12-lead ECG. This is the typical layout of the ECG, and it includes the following. Let me just point this out. So there are 6 limb leads right over here, referred to because these leads are connected to the arms and legs, and they are therefore designated as limb leads. And they are lead 1, lead 2, lead 3, AVR, which stands for augmented vector right, AVL, augmented vector left, and AVF, augmented vector foot. So those are the 6 limb leads in a 12-lead ECG. Now there are 6 chest leads. These are the chest leads, also referred to as V leads, and they are from V1, V2, V3, V4, V5, and V6. Hence, when you look at an electrocardiogram, a 12-lead electrocardiogram, right over here are the 12 views of the heart. Each lead has a sample, as you could see right over here, of 2.5 seconds view of a particular lead of the heart's activity. So from here to here is 2.5, from here to here is another 2.5 seconds. And so the samples are merely 2.5 seconds of the heart's activity. The total sample time from here to here is exactly 10 seconds. Okay? And at the bottom of the paper, right over here, is located the rhythm strip. And some hospitals or some institutions will have 2 views that will give you a rhythm strip. In this particular example, we only have lead 2 as a sample for you to interpret the rhythm of the patient. So at the bottom of the paper, there will always be 1 or 2 leads that has a continuous rhythm strip. In this example, as I said, there's 1 lead, lead 2, and in this lead, this will facilitate your interpretation of the underlying rhythm that is present. Like in this example, we know that this is a sinus rhythm. Okay, so at the beginning or the end of a 12-lead ECG tracing, right over here, that is highlighted, is a mark that is known as a standardization mark. Now, what is this standardization mark? This mark is automatically inscribed by the machine. A normal standard consists of 10 small boxes. So if I were to enlarge these and zoom it, you could actually count that this particular mark encompasses 10 small boxes going up. So what is the significance of this? The significance of this is that you're looking at the electrical activity of the heart as is. Now, there are some instances that the machine has to adjust the writing or the inscription in the paper. For example, if the complexes and waveforms are too large, what's going to happen is that they will overwrite each other, and therefore it will be difficult for you to interpret. And thus, the machine will have to decrease the amplitude or sizes of the waveforms. This is going to be called a 1/2 standard, and it will be indicated in the electrocardiographic paper right here. How many boxes do you see right here going up vertically? Let me just zoom it. How many boxes do you see going up? 5. Okay. So this means to say that now you're looking actually at the electrocardiogram by 50%, it's decreased. So you just want to make sure, or it is just a information for you to understand that typically, or without the machine adjusting, the ECG complexes are very tall. So when would you have a very big QRS complexes, or complexes for that matter? If the heart is enlarged, for example, you will have a very big amplitude of your complexes. So left ventricular hypertrophy will cause a extra large complexes, and therefore the machine will decrease it. The other situations wherein the complexes will be too tall will be in a patient who is very thin. If a patient is very thin with a small chest, obviously the amplitudes of the electrical complexes will be bigger, and therefore the machine has to decrease it in a manner that it will inscribe this half amplitude. Okay? So that is an example of what happens when the amplitudes are going to be too tall. Now, the opposite may also occur. For example, if the ECG complexes and waveforms are too small for you to be able to appreciate, the machine automatically amplifies the normal image twice. And this is called a double standard, such as what is seen in this third frame. So if I show you this amplitude right here, how many boxes do you see that is encompassed by this standardization mark? 20. So understand that despite the fact that you're looking at a normal looking ECG, if this is the standardization mark, you have to understand that it has been amplified or multiplied. So when would you have such a mark? Well, in patients who, for example, have obesity, when they have a big chest or maybe a barrel chest, then that means to say that the complexes that you will see normally would be very small. Or maybe the patient has, for example, fluid around the heart. So pericardial effusion can cause a decrease in the amplitude of the complexes that you will see. So that basically is a discussion on what the standardization mark is. So I'm now going to pause to see if you have any questions so far, because we have talked a lot about different things and I wanted to make sure that everything is clear so far. Do you have any questions? Okay, so that being the case, let's go ahead and move forward. Here's another view of a typical 12-lead ECG tracing. Now, what I wanted to emphasize here is you will see some lines. Do you see these lines right over here? These are actually the lines that indicate the ending and the beginning of each lead. So lead 1 starts from here and ends over here. Lead 2 starts from here and ends over here. So this marks over here should not be misinterpreted as pacemaker spikes. So I used not to discuss this thing, and then I found out that students were misinterpreting them as pacing spikes. These are not pacing spikes. These are merely the dividing lines that separates one lead from another. Okay? All right. So now let us talk about myocardial infarction. We all know what it is, but I just want to touch on the two types of MI. And those two types of MI are called STEMI and non-STEMI. So which is worse, you might ask? Well, the bottom line is that both are just as bad. However, STEMI is seen as more of an immediate emergency because there is a known total occlusion of a heart vessel that needs opening up immediately. However, in terms of long-term outcomes, they have equal health implications. So let me just, for a minute, discuss a little bit. You have a blank screen right now. You might be wondering why you have a white screen. I have put a white screen in order for me to write. But there are two basic types of myocardial infarction. So let's just go ahead and let me draw this. Okay. Okay. Now, whenever we have a myocardial infarction, it is believed that there is an obstruction of circulation and therefore causing death of cardiac tissue. So let me illustrate. If this is just the wall of one ventricle, so this is the endocardium and this is the epicardium. Now, if the damage to the heart or to the ventricle is going to be from one wall to the other wall, meaning to say full thickness from the endocardium to the epicardium, the damage that is going to result from the destruction or death of this tissue is what is called STEMI. So in STEMI, there is a transmural infarction, meaning to say from one wall, from the inner layer, all the way to the outer layer. This results in ST elevation in the electrocardiogram. Now, there's another form of myocardial infarction wherein the damage might just be underneath or above the epicardium, or underneath the endocardium, or in between the epicardium and the endocardium. So there are partial thickness damage to the ventricles. This is what is called non-STEMI, and it doesn't produce ST elevation. Did I make that clear? That in a STEMI, there is wall-to-wall destruction of muscle. In a non-STEMI, there is partial destruction of the muscles of the myocardium. Okay? Was that clear? Thank you. So let's go ahead and move forward. So a manifestation of STEMI or ST elevation MI, as the term denotes, is the elevation of the ST segment. So in this particular slide, this is an illustration of the different waveforms and intervals and segments that we have learned in basic electrocardiogram. We will focus on different areas to help you diagnose the presence of myocardial infarction. So the first thing that I would like to emphasize or to say, hold on one moment, is to identify the baseline. And the baseline, whenever we are talking about the baseline, it is always going to be this segment right here. It is called the PR segment. Now, the PR interval, because PR interval is right here, but the PR segment is this segment or this distance from the end of the P to the beginning of the QRS complex. This is the baseline. And so what's the importance of the baseline? Well, the importance of the baseline establishes the 0 point or the originating point for all waveforms. Okay? So technically, if we have a straight line, and let me just get my ruler over here. I lost my ruler. But anyway, if I put a ruler right here, the baseline should continue all the way to the end of the T wave. Okay, so that's the baseline. The SC segment right over here, the segment or the portion that connects the S wave, this is the S wave, to the T wave is known as the SC segment. These SC segments should be in the same plane as the PR segment. Understood? Okay. So significant deviations are referred to from the baseline as either depressed or elevated. So if this SC segment is below this PR segment, this is what is known as ST depression. If this SC segment is above the PR segment, this means to say that this is ST elevation. So let's take a look at the example on the right side. As you could see on the example of the right side, there is going to be an SC segment elevation because now I am tracing the line that should be the baseline. And as you could see, this SC segment right here is above the PR segment. This is what is known as the ST elevation. Now, one important point, another point that is going to be very important is this, that the beginning of the ST segment right over here is what is known as the J point. And that is exactly what we're going to examine next. The J point is the beginning of the ST segment right over here. Okay? Now, why is this very important? This is very important because this actually determines whether the ST segment is elevated or depressed. The rule here, again, is that the J point, I should say, must be located at the same plane as the baseline. So this is the baseline, this is the J point. They are on the same plane, and this is the expected normal. Now, note on the right side of the slide that there are deviations of the ST segment. So right over here, the first one shows an ST elevation. Do we see the ST elevation? Now, in addition to looking at or appreciating that there is an ST elevation, we need to determine whether or not this ST elevation is significant or not. And this is the reason why we need to measure how much deviation from the baseline it is going to be. So if I'm going to amplify this particular image right over here, the ST elevation, how many boxes is it elevated from the baseline? As you could see, it's already marked 4 small boxes. So 1, 2, 3, 4. So we would call this an ST elevation of around 4 millimeters because each box is equivalent to 1 millimeter. Do we get that? So ST elevation basically is a manifestation of STEMI if it is significant. And we'll define what significant ST elevation is in the next slide. So in looking at the image on the right side, do we have an ST abnormality? Yes, we have an ST abnormality because basically we should have a straight line going here and the ST segment or the J point should be here, but the J point is right underneath it. And if we take a look at it, we could measure the deviation is 3 small boxes. In general, ST depression is a manifestation of myocardial ischemia. So when we have ST elevation, it generally is a manifestation of STEMI. If we have ST depression, we have a manifestation of ischemia. Okay? So I told you that not all ST elevations are going to be a manifestation of myocardial infarction. What constitutes a significant ST segment elevation? In order to diagnose STEMI or ST elevation MI. An ST elevation is considered significant if the vertical distance after the J point is at least 1 millimeter or 1 small square in a limb lead. Limb leads, you remember, are lead 1, 2, 3, AVL and AVF. Or it should be 2 millimeters or 2 small squares in a precordial or V lead. Do we understand that? An ST elevation is considered to be significant if, right over here, if it is more than 1 millimeter above the baseline in the limb leads or 2 millimeters above the baseline in a precordial lead. Now, in this class, we will use this criteria, being aware that some cardiologists may use a different criteria, but in diagnosing as STEMI in a quick manner, we are going to utilize this particular criteria. Okay? All right, there are other criteria for diagnosing STEMI, and they include a new left bundle branch block. And this actually is going to be a significant finding in patients with myocardial infarction. Now, there are other markers of myocardial infarction, and all myocardial infarction could cause abnormal Q waves, and they could also cause inverted T waves. But remember now that we're interested in diagnosing acute myocardial infarction, and therefore we're going to focus on these particular criteria for the diagnosis of myocardial infarction. Let's move forward. Is the ST segment here significant? Could you please answer in the chat box? All right, everybody seems to agree that it is significant. And the significant claim is because the ST segment elevation is 2 millimeters. And therefore, this is going to be a significant ST elevation. Let me just do this. Okay. True or false? Is ST segment elevation always a sign of pathology? Okay, so here's how you responded. Actually, the correct answer is that it's false. ST elevation is not always a sign of pathology. It is one sign of STEMI, or it's the most significant sign of STEMI. But other conditions such as pericarditis might also cause ST elevation. There is also a condition known as early repolarization. It's something that we are not going to discuss today, but nonetheless, not all ST segment elevations are going to be a manifestation of myocardial infarction. All right. So having established that the sign of a STEMI is ST segment elevation that is significant, we're now going to move forward to diagnosing the area where there is an infarction. So ECG changes of ischemia or infarction are considered significant if they are viewed in 2 or more anatomically contiguous leads. That is a mouthful. See, over here, it is considered significant if they are viewed in 2 or more anatomically contiguous leads. So let's identify these 2 contiguous leads. What is a contiguous leads? Now, when we're looking at a 12-lead ECG, actually each lead represents a segment of the heart that they're looking at. For example, if you're looking at the inferior aspect of the heart, and the inferior aspect of the heart is going to be, where are you? Right over here, as shaded in yellow. It is seen by 3 leads, and these leads are leads 2, 3, and AVF. They therefore are called contiguous leads because these leads together look at the inferior aspect of the heart. Okay? So, to better understand the term contiguous leads, look at the color-coded image on the right side of the slide. The colors were added so that you can quickly see the areas of the heart viewed by the same leads. So again, Inferior leads are going to be leads 2, leads 3, and AVF. They're all colored yellow. Now, if we're looking at the lateral aspect of the heart, and the lateral aspect of the heart is right over here, it's shaded blue. These are seen by 4 leads. Leads 1, AVL, V5, and V6. Leads 1 and AVL actually look at this portion of the lateral wall, and V5 and V6 looks at the lower portion of the lateral wall. And therefore, lateral are seen by 4 leads. Leads 1, AVL, V5, and V6. They're all related. So let me illustrate this. If I have ST elevation in lead 2 and another ST elevation is in V6, is this significant? Can you answer? It will not be significant because they're not related. Okay? They're only going to be significant if there are related leads. Related leads are the contiguous leads. So if I had ST elevation in V5 and ST elevation in V6, is this significant? If I have ST elevation in V5 and ST elevation in V6, is this significant? Yes, it is. They are contiguous. Okay? So therefore, that is what it means that there is going to be significant ST elevation if your ST elevation is viewed in 2 or more anatomically contiguous leads. All right. The anterior portion of the heart is viewed by V3 and V4, leads V3 and V4. And these are the anterior portion of the heart marked in red right over here. And the septal portion of the heart is seen by or manifested by leads V1 and V2, as you could see shaded here in green. Okay, are there any questions as far as the leads are concerned? So before we leave this, I'd like for you to write this thing, because in the exercises, we're going to ask you to identify which leads are going to be involved. Okay? So please just make note of these. Now, interestingly, whenever we're looking at a view of the heart, it also tells us actually what artery is involved. And so I'm going to move forward with the next slide. And this slide illustrates the relationship of the ST segment of the heart that is occluded and the corresponding artery that is involved. That's when a patient is diagnosed with a inferior wall MI, for example, the artery that is involved is the right coronary artery. For the anterior MI, the left coronary artery is the one that's going to be involved, including the lateral and the circumflex. So if you take a look over here, anterior, which is this portion right over here, is going to be supplied by the left anterior descending coronary artery. The inferior, right over here, is going to be supplied by the right coronary artery. And of course, the lateral views right over here are going to be supplied by the circumflex coronary artery. So when I have an inferior MI, what coronary artery is involved? If I have an inferior wall MI, what coronary artery involved? Correct. All right. If I have a lateral wall MI, what coronary artery is involved? Circumflex coronary artery. Correct. If I have an anterior MI, I would have a pathology in the left coronary artery. Excellent. Okay. So let's take a look at each type of MI. Let's begin with inferior wall MI. The area that is called inferior wall MI, right over here, as you could see, it's, what do you call that? Shaded. This is also called the diaphragmatic portion of the heart. And that is the reason why a lot of times physicians will diagnose this as a diaphragmatic wall MI. It is the same as an inferior wall MI. They could be used interchangeably. So in most individuals, the coronary artery that is going to be involved is the posterior branch of the right coronary artery. And the anatomical proximity of the segment of the ventricle to the diaphragm explains why this type of MI typically is going to present itself with increased parasympathetic or vagal activity. They vomit a lot, or they can manifest with frequent uncontrolled hiccups. So again, because this particular part of the ventricle is, if this is the diaphragm right here, if you have an infarction in the diaphragmatic wall, it will cause inflammation of the diaphragm. And that's the reason why patients with inferior wall MIs usually will have a lot of vomiting, a lot of vagal effects, and a lot of hiccups because of its proximity to the diaphragmatic wall. Okay? So for those of you who have had experiences in taking care of patient with an inferior wall MI, you usually have noticed this particular symptoms. Now, I used to work in the emergency room, and so when I have a patient presenting with signs of acute coronary syndrome, and I see them vomiting quite a whole lot, I know right away that they have a right coronary occlusion, that they have an inferior wall MI, even before doing a 12-lead ECG. Okay, because this is the typical manifestation of patients with inferior or diaphragmatic wall MI. In addition to the vagal effects that usually accompanies this type of MI, it is usually accompanied frequently by conduction delays, second-degree AV block type 1. They are very common and transient. Having said that, the diagnoses of an inferior wall myocardial infarction are significant ST elevations in leads 2, 3, and AVF. Now, do we have to have all three of them? And the answer to that is no. In order to diagnose myocardial infarction, there must be 2 leads that are contiguous. So only 2 is required. What do I mean by that? If I have ST elevation in lead 2 and nothing else in 3 and AVF, I cannot diagnose an inferior wall MI. But let's say now that I have ST elevation in 2 and AVF, I have the criteria satisfied for the diagnosis of an inferior wall MI. So you must have 2, okay? So the leads that are going to manifest an inferior wall MI are leads 2, 3, and AVF. 2, 3, and AVF. Remember, any 2 combinations is acceptable. It is not necessary to have all 3 leads demonstrating ST elevation. So let's take a look at an example. All right. Let me just give you an opportunity to look at this particular ECG. So let's take a look at the standard. Is the standard normal, or is it half standard or double standard? Your answers? Normal standard. How do we know that it's a normal standard? Again, we count the number of small boxes going up, and this is 10, and therefore this normal standard. So now this is what you do. You go lead by lead. We're going to be systematic about it, and we're going to determine whether or not each lead is normal or depressed or elevated. So in looking at lead 1, here's the baseline right here. Oops, here's the baseline. Is the ST segment normal, or is it elevated, or is it depressed? Is lead 1, the ST elevation, normal, elevated, or depressed? Okay, it's depressed. So we're going to label it D as depressed. For those of you who weren't able to appreciate why it's depressed, I'm going to enlarge it. This is the baseline right here, and this is the J point. It's depressed by 1 millimeter. Okay? All right. Let's take a look at lead 2. What is the situation in lead 2? Is the ST elevation normal or elevated, or is it depressed? All right. So it's elevated, and a lot of you measured it already by 2 millimeters. So that's okay for now. How about lead 3? Let's identify what the situation of the ST segment is in lead 3. It's elevated. Okay, very good. All right. In 12-lead ECG, for the diagnosis of STEMI, we never look at AVR. AVR is only going to be useful for us in certain situations, such as in diagnosing dextrocardia, or perhaps in diagnosing pericarditis. But in a STEMI, or diagnosis of STEMI, which is our topic for today, we do not look at AVR. Okay? So let's skip AVR, and now we're going to go to AVL. What is the situation of our ST as far as AVL is concerned? It is depressed, okay? So it's depressed. For those of you who didn't see that it is depressed, let's take a look at it. See, this is the baseline, and this is the J point, and therefore it's below the J point. So we call that depressed. All right, how about AVF? AVF. All right, it's elevated. Very good. So we have ST elevations in lead 2, lead 3, and AVF so far. Okay. So if you have ST elevations in leads 2, 3, and AVF, which area of the heart is that affected? The inferior wall, okay? So it's an inferior wall MI, and the coronary artery that's the culprit, you already said that, is the right coronary artery. Oh, you're so smart, right? So let's continue with this though. V1 is depressed. V2 is depressed also. V3 seems to be normal. V4 seems to be elevated, but it is not significant. Why is it not significant? Why is V4's ST elevation not significant? In order to be significant in the V leads, right over here in the chest, it has to be 2 millimeters ST elevation. So despite the fact that this is elevated, it is not significant, okay? Same thing with V5 and same thing with V6. So they are all ST elevations that are insignificant. Okay? All right, let's move on to another form of infarction. Before we move forward, I want to make sure that you all understand or don't have any questions. So let me ask again, do you have any questions? Please indicate in the chat box yes or no so that I will know how to address it. Okay. Okay, so let's go to the next one. Now, whenever you have an infarction of the inferior wall, and so let me just give you a picture again of the inferior wall right here. So this is going to be the inferior aspect of the heart. Now notice that this is going to be very, very close to the right ventricle. So there's a possibility that whenever you have an occlusion of the right coronary artery, that you might also have a damage to the right ventricle. So how do we diagnose if there is a myocardial infarction of the right ventricle? Well, this is the criteria. Most right ventricular infarctions occur in conjunction with inferior wall MIs, actually 97% of them to be exact. This is because they're usually caused by an obstruction in the right coronary artery, which, by the way, also supplies the inferior wall of the heart. So whenever you have, I should say, make it a habit to check for right ventricular infarction when you see an inferior wall MI. It should be routine to perform a right-sided chest lead application. That it means to say that instead of applying the leads going to the left, you're also going to apply the leads going to the right. And this will be marked in, there's going to be marked changes in the right-sided chest leads whenever you have a right ventricular infarction. But actually, you could diagnose right ventricular infarction because of the ECG manifestation that I will be discussing. But before we go to the ECG manifestation, whenever you have a right ventricular infarction, is this going to be serious? Because usually the serious ones are going to be the left ventricular infarction. Now, when you have right ventricular infarction, it usually is going to be accompanied by three major symptoms. And these symptoms are hypotension. Remember, when a patient is hypotensive, following an MI, it might be because of right ventricular infarction. It could also be accompanied by jugular vein distension, but this distension is going to be accompanied by clear breath sounds. Usually when you have jugular vein distension, don't you think that the patient is in congestive heart failure and therefore you might hear crackles? But in a patient with right ventricular infarction, you have hypotension, jugular vein distension, but no rouse. In other words, the breath sounds are clear. And the reason why that is that the right ventricular right ventricle may lose its ability to pump blood into the pulmonary circuit. And therefore, it causes this triad of symptoms. This is the reason that in this type of myocardial infarction, nitroglycerin is contraindicated. Let me repeat that. In this type of myocardial infarction, nitroglycerin is contraindicated because of the already compromised and decreased preload from the right side of the heart. If you give nitroglycerin, this would aggravate the situation and cause hypotension and congestion in the central venous system. Let me simplify that, because I think I might have lost some people. Okay, so if we have, it's not writing. One moment. Oh, because, yes. Okay, so supposing now that this is the right ventricle, this is the left ventricle, this is the one that is infarcted. So volume of blood coming into the right side of the heart is what is known as preload. Preload. Now, when you compromise the right ventricle, obviously this load that is delivered to the right side of the heart will not go to the left ventricle, to the left atrium and left ventricles efficiently. And therefore, there's going to be a decrease in your cardiac output. The left ventricle is going to be unable to pump any blood that comes in from the right atrium. And therefore, it causes the hypotension. Okay? Now, whenever you have a right ventricular infarction, therefore, the thing that is going to have to improve the hemodynamic status of the patient is to give fluids. So in these patients, we support them with fluids in order to raise their preload. The reason is the fact that it could not move efficiently because of the compromised right ventricle. It cannot pump blood efficiently into the left ventricle, or the left atrium, I should say. Okay, so that is exactly the reason why we actually are going to avoid the administration of nitroglycerin in these patients. So whenever you have, oh, I didn't erase that. Hold on. So clear. There you go. So whenever you have a inferior wall MI, what I'd like for you to do is to make sure that you make it a habit to check for the presence of a right ventricular infarction. So how do we diagnose that? If the ST elevation in lead 3 is greater than lead 2, then this is going to satisfy the criteria of a right ventricular infarction. So let me repeat that. If the ST elevation in lead 3 is greater than lead 2, then we would have a right ventricular infarction. So let's take a look at an example to drive that particular criteria. So in lead 1, what do we have over here? All right. Michelin, very good example. We would not use inotropes in the presence of hypotension with inferior wall MI unless we support it first with the administration of fluids. All right. So the rule of thumb in use of preso drugs or drugs that increases the blood pressure, such as dopamine or epinephrine for that matter, or norepinephrine, is that we would always increase the volume first, correct the volume problem first before we start them on inotropes. Okay? Did that? Okay, thank you, Michelin. All right, in lead 1, what do we have? What is the situation in lead 1? Depressed. Okay, lead 2. How about lead 2? Elevated. How about lead 3? Elevated. And how about AVL? Depressed. Okay. How about AVF? Depressed. Okay. So let's stop right there. And oh no, this is elevated, right? This is elevated. Okay, let's stop right there. Would you measure the ST elevation in lead 2 and also measure the ST elevation in lead 3? Measure the ST elevation in lead 2 and compare that to the ST elevation in lead 3. How many millimeters is it elevated in lead 2? And how many millimeters is it elevated in lead 3? Okay, so if we take a look over here, how many millimeters is it? 1, 2, 3, around 3. How about in lead 3? 1, 2, 3, 4, right? So which one is taller as far as ST elevation is concerned? Is it lead 2 or lead 3? Lead 3, okay. So because of this criteria, the ST elevation in lead 3 is greater than lead 2, we could therefore conclude that there is a right ventricular infarction. This is the only criteria that I'd like for you to remember. It could also be these two right here, but this one is the most significant. So whenever you have an inferior wall MI and you notice that lead 3 ST elevation is greater than lead 2, then this is going to be the presence of right ventricular myocardial infarction. All right, the next type of MI that we're going to diagnose is the anterior portion of the heart. As you could see right over here, this is the anterior portion. And when you have a occlusion of the anterior, whenever you have anterior wall infarction, it actually rarely presents by itself. It commonly occurs in association with infarction of the septum. It also is going to accompany the lateral wall or both, because as you could see, its proximity to the lateral wall as well. The leads that represent the anterior wall, however, are leads V3 and V4. When both the anterior wall and the septum are affected, the infarct changes obviously from V1 to V4. But anterior infarction is manifested by changes in leads V3 and V4. Septal wall is going to be V1 and V2. Okay, is this clear? So understand now that the anterior portion of the heart may involve these other portions as well. And that is why whenever you see an anterior wall, it might be accompanied by lateral. It could also be accompanied by septal wall. So what are some of the interesting findings whenever you have an anterior wall MI? Well, anterior wall MIs usually are going to be accompanied by the presence of bundle branch block. It is very, very common because the bundle branches are located right over here on this particular area. And that is the reason why it's very common in the presence of an anterior wall MI. Okay. Whenever you see a patient come in with symptoms of myocardial infarction and they are hypertensive, they have fast heart rates, I know right away that the problem is the left coronary artery. If it's the right coronary artery, it usually is the opposite, slow heart rates. If it's the left coronary artery, usually it's slow heart rates. Fast heart rates, I'm sorry. So whenever you see a patient with chest pain and they have tachycardia, suspect that the artery that's going to be involved is the left coronary artery. So it's a hyperdynamic manifestation of myocardial infarction. Hyperdynamic because the manifestations include your hypertension as well as tachycardia. So let's take a look at an example of an anterior wall MI. So as you could see over here, we have, what's the situation in lead 1? Lead 1. Hello. What do you see in lead 1? Okay, so it's slightly elevated, isn't it? How about lead 2? Lead 2 is, so again, always begin right over here. This is the baseline. This is the baseline. Lead 2. It's normal, isn't it? Yes, it's normal. How about lead 3? Again, here's the baseline right here. And so Depressed. Very good. How about AVL? Elevated. Very good. How about AVF? Slightly depressed or normal. Okay, let's go ahead and do that. How about V1? V1, normal. Okay. How about V2? There's ST segment elevation, isn't it? ST segment elevation in V3 as well. Why is this going to be significant? It's more than 2 millimeters. We also have V4. How about V5? Okay. And how about V6? It's only 1 millimeter. Okay, so we have V2, but there's no V1, so we cannot diagnose a septal wall MI. We have V3 and V4, so we have a partner. And what are V3 and V4 looking at as far as the segment of the heart, the anterior portion of the heart? Why can't we not diagnose a septal wall MI? The reason is the partner of V2 is V1, and in V1, it's normal. We could not diagnose a lateral wall MI also because the partner of V5 is V6. This is elevated, but it's not 2 millimeters. Okay. And over here in this is 0.5 millimeter, and therefore it's not significant. So we have an anterior wall MI. Questions? All right, let's take a look at the next one, a lateral wall MI. Now, whenever we have a lateral wall MI, they can occur by themselves by showing changes in 1 AVL, V5, and V6, or they can occur in combination with other infarct patterns, such as in combination with the inferior wall or maybe the anterior wall. The lateral portion of the heart is supplied by the circumflex coronary artery, the left anterior descending artery, or a branch of the right coronary artery. So, in essence, then, when you have a lateral wall MI, as you could see, as labeled here in is it yellow, are your lateral leads. Leads 1 and AVL, V5 and V6. So let's take a look at an electrocardiographic pattern that demonstrates the presence of a lateral wall MI. So let's take a look at lead 1. Is lead 1 normal, elevated, or depressed? Okay, so it's elevated. How about lead 2? Lead 2? Okay, so normal to depressed. All right, how about lead 3? Lead 3, depressed. How about AVL? Elevated. And how about AVF? Depressed. Okay. And V1? depress, V2, depress, V3, depress, and V4, V4 is slightly elevated, right? Okay. And V5, and V6. Okay, so we have ST elevations in 1, AVL, V5, and V6. V4 is elevated, but it does not have a partner, so we cannot claim that there is an anterior wall MI. So in this particular example, we have a lateral wall MI. Okay, so in this particular presentation that we have had, we have identified the markers of STEMI, and they are an ST elevation that should be significant. Significant means to say that there is going to be a 2 mm elevation in the V leads or 1 mm in the limb leads. Or, and I should say, that there should be in 2 contiguous leads. Okay. Michelin, very good question. Michelin's question was, in high lateral wall MI, which lead signifies it? It's signified by leads 1 and AVL. And so let me just go back to this one right over here. As you could see in the lateral wall, we could divide this into right here, 1 and AVL as high lateral. That's this portion right here. And low lateral, which are V5 and V6, that would be this portion right over here. Okay? Yes, thank you, Michelin, for raising those questions. Okay, it's time for you to work. And so I'm going to ask you to go to the same system that we have done. I'm going to give you a 12 lead, and I will allow you at least 3 minutes to analyze and come up with an answer. Okay, so let's take a look at the first one. Okay, this is how you responded. Most of you said anterior, inferior, and right ventricular wall MI. So let's take a look at the correct answer. All right, so lead one is depressed. You all agree that it's depressed? And lead two is elevated. And lead three is elevated. AVL is depressed. AVF is elevated. So we have elevations in lead two, in lead three, and AVF so far. So we have inferior wall MI so far, correct? Does everybody agree that we have an inferior wall MI? Okay. In looking at the ST elevation of here, there is 2 millimeters. And the ST elevation here is 1, 2, 3, 4. So we also have a right ventricular wall MI. Why do we say that there's a right ventricular wall MI? Anytime we have an inferior wall MI, we need to see if the right ventricle is involved. And leads 3, ST elevation of 4 millimeters is greater than the ST elevation in lead 2. So yes, we have right ventricular infarction in the presence of an inferior wall MI. Going further, we look at AVL, and AVL is depressed, right? And V1 is going to be slightly depressed. V2 is depressed. V3 is normal. V4 is, it didn't give us enough, but it looks like it's normal. V5 is also depressed, and V6 is depressed. So the significant one here, therefore, is an inferior wall MI and a right ventricular wall MI. All right, that's the correct answer. Let's go to exercise number 2. Okay, so this is how you responded. And let's see what the correct answer is. All right. So there's ST elevations in the following leads. V1. Do you all agree? V1. There's ST elevation in V2. There's also ST elevation in V3, as well as V4. Normal in V5 and V6. So our infarcted areas are your septum, septal infarction, V3 and V4, your anterior. So we have an anteroseptal MI. Okay, anterior and septal. There was no inferior. There was no lateral wall infarction. Let's take another one. All right, this is how you answered. And let's see. Lead 1 is elevated. Lead 2 is slightly elevated. Lead 3 is depressed. AVL is elevated. AVF is normal. V1 is normal. V2 is elevated. V3 is elevated. V4 is elevated. Come on. My pen is not going to the V4. V5 is elevated and V6 is elevated. So we have elevations in 1 AVL, V5, and V6. So that's the lateral wall MI. So 73% of you got that correctly. And in addition to that, we have ST elevation in V3 and V4. That is the anterior wall, and 82% of you got that correctly. Okay, that's very good. Are there any questions with that one? Any questions with that particular ECG? Okay, let's go to the next one. Okay, so let's see. This is how you responded. All right, the ST elevations are in lead 1, that's elevated. Lead 2 is depressed. Lead 3 is depressed. AVL is elevated. AVF is depressed. Okay. V1 is elevated. V2 is elevated. V3 is elevated. V4 is elevated. And it will, there you go. V5 is normal. And V6 is normal. Okay. So we have ST elevations in 1 and AVL. This is a high lateral wall MI. So yes, we have an MI. Because you remember, you need 2 or more contiguous leads. And 1 and AVL look at the lateral wall. None of you were able to identify that, but it is a lateral wall, high lateral wall MI. And we have ST elevations in V1 and V2, that's septal. Good, 100% of you got that. And V3 and V4 is anterior, and 83% of you got that correctly. Okay, and let's move on to the next one, unless you have any questions. Okay, so let's take a look at lead 1, it's depressed. Lead 2 is elevated. Lead 3 is elevated. AVF is elevated. AVL is depressed. V1 is normal. V2 is depressed. V3 is normal. V4 is depressed. V5 is depressed. And V6 is depressed. Okay. So we have ST elevations in 2, 3, and AVF. That's inferior. The ST elevation in lead 3 is greater than the ST elevation in lead 2. So we also have right ventricular infarction. So this is how you responded. And so you're doing pretty well. Okay. And one last one before we go to our Kahoot. And let's see exercise number 6. Okay, so let's take a look. Lead 1 is normal. Lead 2 is elevated. Lead 3 is elevated. AVL is depressed. AVF is elevated. And we have V1 is normal. V2 is normal. V3 is elevated. My pen is stuck. Come on. V4 is slightly elevated. V5, there you go. V5 is normal and slightly elevated, but not significant. And again, this is only 1 millimeter. So it's slightly elevated. So the significant ones are going to be your 2, 3, and AVF. So we have an inferior wall MI, but the ST elevation in lead 3 is not more than that of lead 2. I think they're both 2 millimeters. So there's no right ventricular infarction. And of course, we have V3 and V4, and that would be your anterior wall. So you have an anterior wall MI as well. Okay, so great. And this is how you responded. All right, we have finished the discussions on identifying STEMI using the 12-lead ECG. Remember now that whenever you have a significant ST elevation, part of ACS protocol is also obviously to look at biomarkers in order to confirm the diagnosis of myocardial infarction. So at this time, what I'd like to do is to play Kahoot. So for those of you who are joining us for the first time, Kahoot is a game that is going to help us evaluate what we have actually learned. So I'm going to give you the information as far as Kahoot is concerned. And this is the information. What I'd like for you is to open a browser on your phone or your computer and type www.kahoot.it and follow the instructions. Enter the code appearing on the screen and type your name for this game. Questions will appear on the screen and your device will show a color-coded response menu. You will answer on your device by choosing the appropriate color. Note that the questions appear only on the Zoom screen. The object is for you to respond correctly and quickly, and you win by demonstrating accuracy and speed. So I hope that you are going to have fun in the process of learning. So let's go to Kahoot. Let me just go and find it. Uh-oh, there you go. And start. And I'm going to share my screen. All right, so go to kahoot.it and you're going to type this game pin that's going to appear in a few seconds. Here it is. Go to kahoot.it. For those of you who are new, just go to kahoot.it on your phone And you're going to be asked to enter this game pin appearing on the screen, 823558. Great. So Ellen, Dimps, Riza, May, Ania, Drain, or Drain, Eileen are all in. We're gonna wait for the others. If you're unable to join, you still could watch and learn from the questions, okay? Okay, if you're not able to access, just stay on the line and watch how it's done. Uh-oh, only 6 people so far. Okay, let's go ahead and get started as a demonstration. Okay, so let's see. Somebody from Singapore, UAE, Qatar, Trinidad, and Jamaica. Excellent. Thank you. Let's go to the next one. Okay, so we have an intermediate, a basic, and an expert. So that's great. All right, let's go to the heart office. Okay, so the PR interval is not going to be of use for the diagnosis of myocardial infarction. Inverted T waves are manifestations of non-STEMI. Elevated ST segments obviously are manifestations of STEMI. And abnormal Q waves are going to be manifestations of old MI. So the only one that's not going to be is the PR interval. So let's see. The one in the lead is Drain, Eileen, Ania, Meg, and May. Congratulations. Okay, so in here, this is the J point. Letter C is the correct response. And let's see who got that the quickest. Okay. Drain again, Eileen, Ania, Meg, and May. Congratulations. All right, the correct answer is 1 millimeter in the limb leads, 2 millimeters in the V leads. Unfortunately, a lot of you thought that it was 2 millimeters in 2, 3, and AVL. These are the limb leads. You only need 1 millimeter. Okay. So let's see. Nobody got that correctly. So nobody is a winner. Okay, great. Everybody got that correctly. But the quickest one was Drine, Eileen, Ania, Rita, and Meg. Congratulations. Okay, if you have an inferior wall MI, which are 2, 3, and AVF, that means to say that that would be an occlusion in the right coronary artery. So again, Brian, Eileen, Risa, Ania, and Meg are in the lead. Okay, there's an inferior wall MI. And so let's see why there's an inferior wall MI. There's ST elevation in lead 2, in lead 3, as well as AVF. So therefore, this is a manifestation that there is an inferior wall MI. Okay. And so let's see who got that correctly. And quickly, Eileen, Dwayne, Risa, Ania, and Meg. And Eileen has a streak of 3 correct answers in a row. Okay, so the correct answer is inferior wall and right ventricular wall, as well as the septal wall MI. So let's take a look. We have ST elevation in 2, 3, and AVF. And the ST elevation in 3 is greater than in lead 2. So in addition to inferior wall MI, we also have a right ventricular wall infarction. V1 is elevated and V2 is elevated. So these two is going to be septal wall. V3 is elevated, but not V4. And therefore, we cannot diagnose an anterior wall MI in this particular instance. So the correct answer is an inferior wall, right ventricular wall, and a septal wall MI. And Eileen, Drine, Risa, and Ania and Meg are in the lead. Okay, so everybody got that correctly. Leads 1 and AVL are going to be your high lateral wall. Eileen, Drine, Risa, Ania, Meg, again, and Eileen has the highest streak. It's all distributed. Let's see. Okay, we have ST elevation in 2, 3, and AVF. And the ST elevation in 3 is greater than lead 2. So we have inferior wall and right ventricular wall MI. There's no other ST elevations anywhere else. So that's the only one that is going to be correct. So the one that got that correctly is Drine. All right. You also have the highest answer streak. Congratulations. Okay, so let's see. There's ST elevation in V1, V2, V3, and V4. And that's it. So V1 and V2 is septal, V3 and V4 is anterior, and therefore the correct answer is anteroseptal wall MI. 2 of you got that correctly, and congratulations again to Drine and Eileen. Okay, the correct answer is an anterolateral wall MI. We have ST elevation in lead 1 and AVL, that's lateral, right? We have ST elevation in V2, but not in V1, so we cannot claim septal. V3 and V4, this is anterior. V5 and V6, which is going to be lateral. So it's an anterolateral wall MI, V3, V4, V5, V6, 1, and AVL. Okay, and so one of you got this, one of you got this correctly, and Drine, congratulations. Okay, so let's see. The correct answer is an anteroseptal wall MI. Notice that there's ST elevation in V1, V2, V3, and V4. V1 and V2 is septal, V3 and V4 is anterior. And so the correct answer is anteroseptal wall MI. Oh, a lot of you got that correctly. Very good. Drine, Eileen, Risa, Ania, and May are still in the honors. Okay, a lot of you got this correctly. There's ST elevation in 2, 3, and AVF. So there's an inferior wall MI. Anytime we have an inferior wall MI, we need to check if there's right ventricular MI as well. And if we could see over here, the ST elevation in lead 3 is greater than lead 2. So there is right ventricular MI. And so the correct answer is inferior wall MI plus right ventricular wall MI. And Brian, Eileen, Risa, Ania, and May are still in the honors. Okay, I just wanted to check whether or not you remember that the other term for inferior wall MI is also diaphragmatic wall MI. So we have ST elevations in 2, 3, and AVF with an ST elevation greater in 3 compared to lead 2. So we have a right ventricular MI as well. And Brian again, and Eileen, Risa, Ania, and May. Okay, so over here we have ST elevations in 2, 3, and AVF, and the ST elevation in 3 is significantly higher than in lead 2. So in addition to inferior wall MI, we have also a right ventricular infarction. And right ventricular infarction, there's a contraindication to the use of nitroglycerin. And therefore, it's important to remember that we need to treat them with fluids. So on third is Risa, second is Eileen, and the first is, let's see, Ryan. Congratulations to everyone. And Ania and May are runners-up. Okay, so once again, I'd like to thank you for your participation in this webinar. I look forward to meeting again all of you in future webinars. We have this every Monday, so whenever you have an opportunity, do join us for the webinars. Once again, it is my pleasure to be a part of this journey, and I encourage you to join in future webinars as well. You will be receiving a link to the evaluation, as well as I wanted you to know that the recording of this webinar will be available to you within the day. The PowerPoint that accompanies this webinar will also be posted in Canvas. So I want to say thank you and goodbye to everyone. I will be available for the next 20 minutes to answer your questions.